takes loss of life, takes more chances of death. They have to earn more because of the morbidity and mortality associated with this significant disease. Up to 1993, there is a process and there is a desperate attempt to control the blood sugar was the only attempt. Just because to reduce the blood sugar level, after 1993, last 30 years back almost, we started to know that we need to control diabetes not only for the loss of mortality, also to reduce the end organ dysfunction like nephropathy, retinopathy, or cardiovascular diseases. But in last 15 years time, we have also known that only glycemic control may not be enough. We need some additional therapies which is not targeted directly to the glycemic control, but still have some impact on the life of a patient with diabetes, some amount of renal dysfunction or some amount of the cardiovascular morbidity. Like this patient, the 50 years male with the type 2 diabetes for last 10 years with adequate diabetic control with HbA1c of 5.5, blood pressure control is okay. But the problem is serum creatinine is 1.6 with an estimated GFR is almost 52 ml, slightly low, and urine albumin creatinine ratio is 800. So what should be the perfect approach for such patients to reduce the mortality of this group of patients? That I have already told that 1993 to almost 2008, all studies have been targeted towards the glycemic control to achieve the goal of the end organ damage, effect, impact. But additionally, nowadays, all of us probably has changed our practice for such patients. Whenever they come to our clinic, we ask them to do 2 additional tests, that is a creatinine value which is utilized for the estimation of the GFR and urinary protein test which is estimated to be urinary albumin creatinine ratio. That is also the recommendations. You should test an ACR. We should get an urine analysis to get an idea how much protein is passing in the urine and how much kidney is functioning, that is measured by in terms of the GFR. So why this is so? Because if the patient is an albuminuric, he has more chances of death. The terminology of the albuminuria has been changed over the years. Initially it was a micro and macro, so confusion was a micro protein or a micro amount. So that these things has been changed. Now it is called if it is less than 30 ACR, it should be normal, moderate or mildly increased, moderately increased 330 to 300 and severely increased. That is the terminology that replaced the old micro and microalbuminuria. Any patient who is having a proteinuria in terms of microalbuminuria or a macro, he has a more chance of death. He may be diabetic, he may not be diabetic. You can see the blue columns are for the non-diabetic patients and the red columns are for the diabetic patients. Amount of the proteinuria associated with the mortality, you can see the mortality is lowest in this subquartile and this is highest in this patient is diabetic and is proteinuric, and more proteinuric, more chances of death. So every diabetic patient is converted to the diabetic nephropathy. Suppose in a patient who is a diabetes and having no kidney disease develops a microalbuminuria in 2% per year and there is a 1.4% increase in the mortality. If a microalbuminuric patient becomes overt albuminuric, every year is a possibility is 3%, the chances of death also increases by 3%. If a microalbuminuric patient at the same time causes a loss in the GFR, there is a 20% chances every year of increasing mortality. So if a diabetic patient develops a proteinuria and a loss of GFR, there is a more chance of death in terms of cardiovascular disease, death in terms of kidney disease. So the identification of this presence of these 2 factors are very important in the life of a diabetic patients. You can see what I have already told. If the patient has a proteinuria, more chance of death. If the patient is having a low GFR, even more chance of death. So it is a recommendation for any diabetic patients, particularly type 2 diabetic patients, which you all see, to test for this albuminuria and estimation of the GFR by using simple formulas to assess the mortality risk. And this is more important if the patient already develops a disease. That's a recommendation. You should check every 6 months time for such patients. Instead of which patient does he have who has not developed the disease, you can check it in once in a year time. But this is not so simple. You can see this is the diabetic patient's proteinuria trajectory. Ideally, I have told that the patient is a diabetic. After some time, he or she develops a proteinuria. That proteinuria worsens with time, and after some time, there is a loss of GFR, and after GFR loss, there is a kidney failure. But significant number of these patients, around 25 to 30% of the patient, if you diagnose them, treat them, there is a complete reversal of the proteinuria proteinuria, and these patients who do not recurrent, there is no recurrence of proteinuria, they live more. So there is always a possibility to identify a high risk proteinuric patient from a low risk proteinuric patient, because a patient with diabetes, if he develops proteinuria, worsens in spite of treatment, is a bad diabetic patient. A patient is having a diabetes with a proteinuria which reverses with simplest therapy like ACs and ARBs, the good diabetic nephropathy patients. But some patients, due to genetic factors, you can see this rapid decline of patients. Some young patients we have already probably have all seen this patient develop a diabetic nephropathy, retinopathy, cardiovascular disease, worsens like anything, doesn't respond to treatment, die early even due to the best of the treatment. Probably genetic factors will act on this. And there is a significant number of the patients who doesn't follow any rule. The diabetic kidney disease patients who are non-diabetic nephropathy. Means they have a disease, maybe a tubulointerstitial disease, may have a pyelonephritis, infarct, or maybe so many things that's in the disease. We call it a diabetic kidney disease. So the proteinuria detection is important to identify the good patients, the bad patients, the most treatable patients, and wherever treatment is slightly different such patients. So doing a urinary SCI test is important. Second is the estimation of the GFR. There is all formulas are available, but I am giving one or two lines on each. Initial classical formula is a Cockcroft formula. You can see that is utilized because it has been studied in a very small group of patients, only hospitalized patients. That's why they are not very useful for patients of ours, like a diabetic patients with a creatinine of 1.5. They are useful in terms of assessing your drug dosage, because many of the drugs in the renal clearance, and you have to reduce the dose according to the renal clearance, and all the product monograph utilizes Cockcroft formula. So whenever you are using the drug, that is helpful in this formula. Second, part 2, this is the MDRD formula, this is the CKD API. MDRD has been studied on the patients' GFR of less than 60. Compared to the API formula, which has been studied in more high percentile populations, and they have a GFR of more than 60. So one liner is that Cockcroft formula is useful for assessing your drug dosage. MDRD formula, when your GFR is less than 50, it is very 60, very accurate. When your GFR is above 60, then the CKD API formula or CKD API formula is good for everyone. So whenever a patient comes to you, test for albuminuria, you assess for the GFR, you can put it in your mobile and assess the GFR, and accordingly you can stage them, because KDIGO and the world guideline have given us to stage them in terms of GFR and the proteinuria. You can see this is G1, G2 according to the GFR, and this is the proteinuria, and you can put the patient like our patients in the exam. This is the CKD heat map, and that's why you can know how long you have to follow up, how frequent follow-up is needed, when you have to refer the patient to a specialist, when he needs an advanced care, when he needs some hospitalization, like that. So whenever a patient comes, creatinine of 1.5, GFR of 52, proteinuria of 800 milligram, you can put him or her in this roadmap, and so the treatment becomes easier. So if a patient with this idea of proteinuria and the kidney disease, if the patient doesn't have any kidney disease, chance of death is much lower compared to the patient who has both loss of GFR and the proteinuria. So what to do? These guidelines, probably in such group of patients, your diet control, exercise control, smoking cessation, weight reduction may not be enough. Your lipid management, glycemic control, blood pressure control also may not be enough. In such situations, you need some additional treatment which is not directly towards the glycemic control, but may have mortality benefit. Here comes the concept of this pillar-based approach. This is glycemic control, this is blood pressure control, lipid management, or other dietary management. You need a RAS blockade, maybe an SGLT inhibition, maybe a non-steroidal immunotherapy. So these pillars, initially, these pillars are also targeted towards the RAS blockade, which typically acts in the afferent and this efferent artery, directs them and causes a loss in the decrease the intracranial blood pressure, so hyperfiltration reduces and ultimately kidney is protected. It also acts at the tissue level to prevent the fibrosis. At the same time, if you use this SGLT2 inhibitors, you know this causes an afferent arterial inflow reduction and reduces the intracranial blood pressure, so prevents the proteinuria. It also prevents by other action, it reduces maintains the GFR and its anti-inflammatory actions also. Third pillar is this MRAs, or these field-renal non-steroidal MRAs. They probably act mostly on the tissue level to prevent the fibrosis and inflammations. And the GLP-1 analogs, there is not in the tissue but mostly on the systemic level to reduce the diabetes, to reduce the obesity, to reduce the lipid, and to the in protecting the kidney and heart of such patients with a GFR of 50 and proteinuria of 800 milligram. So RAS blockade has long been included in the recommendations that all patients of the kidney diseases of diabetic kidney disease should be prescribed the ACEs and the ARBs. They act by different mechanism. I have already told. They cause a slowing in the progression of the kidney disease in such patients. So lots of evidences are there. ACEs were there in the market long before and they were tried. Then ARBs were there after 15 years. They have been tried. As they have a different time span, there will hardly any head-to-head comparative study between the ACEs and the ARBs. But they have told that they are better in comparison to the placebo. These all trials are against the disease and against the placebo treatment. They have told Practobdil is best. You can see this Irbesartan is better than placebo. They can see this Irbesartan is again better than placebo. Losartan is better than placebo. Telmisartan, okay. So all these drugs are better than placebo. So diabetic kidney disease should get an ACEs and the ARBs. Alone is not efficient. So there has always been a head-to-head comparison or a combination versus placebo therapy. They suggested that yes, one is not enough. Maybe they are equally effective. Combination works better in terms of the RAS inhibition, but at the cost of the side effect, particularly loss of GFR and development of the hyperkalemia. So these are the all things. With the ACs, you can block the 55% of the RAS systems. With the ARBs, you can block hardly 60 to 65% of the RAS system. Combination, you can block more than 80%, but at the cost of hyperkalemia. So, what is the risk if you increase the dosage or if you combine these ACEs and the ARBs? One is the hyperkalemia, another is the loss of the GFR. You know, this stopping of a drug due to side effect is very easy, but it is very difficult to reinitiate the drug. You can stop the drug for some time, but after some time they will ask you that yes, doctor, these drugs cause side effect, so don't start this drug, and we are also hesitant to starting this drug. So before stopping, the guidelines strictly comments that you should exclude the other causes of this side effect. Suppose there is a hyperkalemia and a patient is getting ACEs or the ARBs, you should consider that whether he is getting an additional drugs like NSAIDs, whether additional sodium, potassium increasing drugs, maybe a Lona salt, or maybe your patient, your blood collector has taken the blood from Durgapur and going 50 kilometers away in a bike, causing significant hemolysis of the blood, causing pseudohyperkalemia. So before you ensure that, and if you are sure that yes, there is a significant hyperkalemia, then you can reduce the dose initially. If it's more than 5.5, the recommendation to stop them and restart them once it is in the range that is less than 5.5. So also for the loss of the GFR, you estimate the GFR, start the drug. You can recheck the GFR at 1 week or 4 weeks time. If this is less than more than 30% decrease, you look whether the patient has taken an NSAID, whether the patient has undergone a CAG in between, whether the renal artery stenosis is underlying or not. If all these things are excluded, then you can reduce the drug or you can stop the drug for the time being. So some drugs require the modifications of the doses in terms of the GFR, particularly ACEs are restricted in the kidneys and they need such modifications with the loss of the decrease in the GFR. ARBs are mostly restricted hepatic excretions, they don't require a dose modification with the loss of the GFR. So already I have already told so how to tackle these two drugs, but with time we have known, with the last 20 years or so, we have known that ACEs and the ARBs are not enough for preventing mortality of such patients. So came in the era of these efflogens, and they are already, the first time recommendation for all bodies, they recommend treating a patients of type 2 diabetes of CKD and epilepsy for more than 20%. Difference between ACEs and the ARBs and SGLT2 inhibitors is that you can prescribe this SGLT2 inhibitors in a patient who has not developed a kidney disease to prevent the development of the kidney disease. But ACEs and the ARBs, if you put it the patients who has not developed a kidney disease, suppose a creatinine of 0.8 GFR or more than 80, no proteinuria, to prescribe ACEs and the ARBs, there is no preventive capability of such group of drugs for the time terms of nephropathy. But SGLT2, by their inherent action, anti-glycemic action, they have this action, so they can be used as the first line of agents in such cases. The more trials initially was on the endocrine and the cardiological point of view. Nephro was on the second line, is a sub-classification of the other parts of the Hasman studies. These three trials was particularly targeted towards primarily the kidney patients. This is the initial Credence trial which showed that patient with type 2 diabetes with a canine reduces risk of kidney failure. Mind it is all diabetic nephropathy patients. Then the DAPA CKD, which is a 40% non-diabetic patient, showed that is a proteinuria. If there is a increase in the GFR, there is a mortality benefit and in terms of renal, cardiovascular and renal mortality benefit. And this MPAC kidney, you have already known MPAC reflosion, they have also diabetic patients and the non-diabetic patients, they have a preventive effect in a patient in terms of cardiovascular and renal. The problem challenges with such patients in a case of a low GFR, whether you prescribe or not, at a GFR of less than 45, by mechanism glycemic anti-glycemic action of SGLT2 is lost. By the GFR of 20, by this time you will hardly get any benefit in terms of kidney because tubuloglommerular feedback is lost. So below 20 you can continue the SGLT2 inhibitors to get the pleiotropic action and cardiovascular benefit. So initially it is in the hand of the endocrinologist or the diabetologist, subsequently nephrologist and ultimately to the cardiologist's hand. See, there is a problem, infection is an issue, and AKI. These things has been evaluated extensively and cleared that for a C it is not a good drug. In presence of infection, not the UTI but genetically fungal infections only. In those situations, you should stop the drug for the time being till it is clear. If it is recurrent and the patient is immunocompromised, you should not continue. AKI is not an issue, it is a very safe drug in use in AKI. Even some AKI patients have been studied with this drug. And this is a class with which one is better, DAPA is better, or MPA is better, or CANA is better. This is basically but there is some differences in the pharmacokinetic, and in some cases the binding is better. So there is a recommendation in the DAPA. If with UTI, you can reduce or stop the drug. That is not recommended for other. So there is a another issue is the reversible decrease in the GFR of such patients in the SGLT2 inhibitions, whether for the stopping, because by mechanism it dilates afferent arterial, it is constant afferent arterial, so increase the GFR is a normal phenomenon in this drug. It comes up and normalizes within 6 months. So loss of GFR probably is not an indication for withdrawal of the drug, even if it is more than 30%, unlike that of RAS inhibition, but it should stop for some time and restart again. So this is I have already told this is AKIs and comparison of the if you compare with the other organisms, chances of AKI is not much. This is a recent trial which showed the combinations of SGLT2 inhibitors with the MRAs, the mineralocorticoid antagonist, and they have shown that if you combine these two drugs, you have a robust effect in terms of reduction in proteinuria as well as mortality, but you have to look for the hyperkalemia. So I have already told that different trials have shown glycemic control is important, RAS inhibition is important, SGLT2 inhibition is important, and with this third pillar it is required because mortality goes up with this SGLT2 and the RAS inhibitions. So you have to treat it with the mineralocorticoid antagonist, fibrinogen, that acts mostly at the tissue level to reduce the mineralocorticoid, to reduce the fibrosis, which is the most potent factor for the progression of the kidney disease, and that has been initially started in the animal model. And recommendation comes that this yes, it should be given to every diabetic patient. So GFR more than 25, and most importantly, they have told they should have albuminuria for more than 30 milligram. We get many prescriptions for prescription of fibrinogen. The patients who don't have any albuminuria. All studies have shown if there is no albuminuria, there is hardly any impact of fibrinogen in this group of the drugs. So there's lots of trial initially on the heart, particularly subsequently on the patient. The Fidelio trial. Fidelio is basically a drama that is written by Mozart. Initially came as an opera. This is flopped. Like this drug initially came at like a calcium channel blocker, subsequently with the mineralocorticoid antagonist. We are all aware about the Fidelio trial, Figaro trial, and a combination of these two. This is a fidelity trial which showed that if you give them in a patient who is albuminuric, who is a patient who is adequately blocked by RAS inhibitions, and if these two criteria is fulfilled, and then you give these drugs, you can get a benefit in terms of cardiovascular composite endpoint of 14%, you can get a kidney composite benefit of 23% like our patient, it can be given. So by these three pillars, the treatment can be continued. And you can see this is the figure of Fidelio combined, and it has been tried also in the type 1 diabetes patient. RAS inhibition has been studied extensively in the type 1 diabetes patient. SGLT2 at this present moment is not recommended for the type 1 diabetes patients, but fibrinogen is probably a drug which can be used in the type 1 diabetes patients. So whether these drugs can be combined or not, recent study by the confidence trial have shown the combinations of simultaneous use of fibrinogen and SGLT2. You know that both of RAS inhibition and SGLT2 causes a loss in the GFR. So if you start together these two patients, these two drugs, there will be chances of development of acute reduction of the GFR. But this study has been shown that if you start in Finland along with the SGLT2 inhibitor, there is a more benefit in terms of proteinuria compared to if you use Finland or the SGLT2 or the empagliflozin alone. You see, this is true for this all diabetic patients having a proteinuria of more than 30. So these two drugs reverse the proteinuria and they are more effective as the GFR goes down. Below 60, more proteinuria, more benefit. So the challenges are again the hyperkalemia, decline in the GFR, and there is no proteinuria, I have already told. The side effects profile are more or less similar to that. Other side effect profile more or less similar to that of the placebo. It doesn't cause loss of GFR much, it doesn't cause an acute kidney injury, it doesn't cause a fall of blood pressure. But hyperkalemia is a problem. So whenever you start feeling down, you should look. That patient should get an SCs on the ARB. You start at a lower dose. If the GFR is high and there is a proteinuria, you can start directly with the 20 milligram. If the GFR is low, in these cases, if the potassium is less than 5, you can start with 10 milligram. Recommendation is to check potassium at 4 weeks of time. If it is less than 5.1, you can increase your dose to 20. If this is less than that, if more than 5.1, then you should not increase your dose. At more than 5.5, you should stop the drug and you should monitor after 4 months and every 4 months they are out. So this is a drug that causes hyperkalemia in some patients, but in not all patients. You have to look for the other causes when the patient is utilizing other hyperkalemic drugs at the same time or not, taking a salt having low high potassium, diet having a high potassium or not. But whenever this, you should use strategically to get a significant proteinuria reducing actions. This is the recommendation. I am not going into the detail. So it is a drug which is recommended for the treatment for these patients, but not for the patients who have, at the same time, this kind of patients who have GFR of 50 and as a proteinuria, they have a low ejection fraction. For any heart failure patients with low ejection fraction patients, these drugs are not recommended. This is also not recommended whenever there is a significant hyperaldosteronism or a refractory hypertension because they don't have any antihypertensive action. So if these patients are low ejection fraction, as a hyperaldosteronism and refractory hypertension, in those situations you should prescribe steroidal MRAs in comparison to the non-steroidal MRAs like the spironolactone, but you have to look for hyperkalemia. So you can see 1, 2, 3, 4, they have a recommendation for the non-steroidal, and fifth one, they have a recommendation for the steroidal one. So almost with all these drugs, we have probably we have thought that we have controlled everything, but it is not so. Still, the patient goes on deteriorates. Everyone has this. The newer drugs, I don't have much experience of using these drugs. But these drugs act mostly by the systemic effect, reduction of obesity, control of diabetes, and this other systemic effect. These are the different drugs. The scenario has changed in the post-flow trial, which showed that this GLP-1 analog, when we use it alone, is definitely beneficial in terms of renal protection. Protein reduction is okay, at the same time, GFR reductions is also there. One thing is important, one thing is beneficial for these drugs, there is systemic effect, which other drugs don't have much. At the same time, it can be used at the end of the GFR. You cannot use a RAS blockade, it's a very low GFR patient to get a renal benefit, but you can use a GLP-1 analog with a very low GFR without much dose modifications. So we started with anti-glycemic drugs, we added, this is the anti-hypertensive, anti-lipidemic, we added RAS inhibition, SCs and ARBs, the SGLT2 inhibitions, the non-steroidal anti-inflammatory drugs and GLP-1 analog, and combination of drug works for such patients. They give a more benefit in terms of cardiovascular and renal mortality. This is a recent publication. But how? It should be given simultaneously or a sequential one. Some things are clear by this time, which is very fast. Some days back, you can start SC inhibitor alone. It is better not to start an SC inhibitors and SGLT2 simultaneously, so that a development of the AKI is there. If you do that, it is sequential. Once you start SGLT2 inhibitor, then you can start simultaneously after this confidence trial. This is the Finland can be started simultaneously, and the GLP-1 analog still the add-on for such patients. So if we go back to our patient who has developed creatinine of 1.6, GFR of 52, we have given all these drugs. You can see the weight per meter and what benefit we have got for such patients. As I am taking, this is the patient and if you just develop nephropathy at this point, if you don't treat him, you will end up in extreme kidney disease and probably will die by this time. If you have glycemic control and hypertensive control like that, your lifespan or kidney life can increase up to this. And if you add on this 4 pillar based therapy, you can take him almost near to the normal, maybe it may not be the normal, but almost near to the normal by using these drugs. This is the benefit, this is the conceptual approach towards a patient who is having a diabetes with optimum control, who is having a slightly loss in the GFR, who is having is a slight proteinuria, but significantly high risk of mortality. How to treat such patients and overcoming this? That can give a life of patients with this in this era of advanced insulin and oral glycemic. Thank you.